Welcome to the webinar series on epilepsy from the Epilepsy Foundation and the American Association of Neuroscience Nurses. My name is Patty Osborne Schaefer, and I work with the Epilepsy Foundation, and I'm also a member of AANN. And I'm pleased to bring you this presentation today. These educational programs are supported by a grant from the Centers for Disease Control and Prevention to the Epilepsy Foundation called the National Epilepsy Education and Awareness Collaborative. AANN is a partner in this grant and is working with us to educate healthcare professionals who care for people with epilepsy. Through this grant, we also want to help improve access to care and epilepsy services, especially in rural and underserved areas or groups, and encourage care coordination and use of self-management programs that people with epilepsy need to enhance their quality of life and their epilepsy management. One of the main areas of focus, and one I personally feel is critical for nurses, is understanding the comorbidities or associated health problems that people with epilepsy may encounter. These are frequently overlooked by healthcare providers or not addressed during visits, as they might be outside the scope of that initial encounter. Yet for people with epilepsy, the literature has shown time and again that comorbidities, especially mood disorders, have a greater impact on quality of life than seizures. Next slide. So today we're giving an overview of pediatric and adult comorbidities. Our guest speakers are Mimi Callanan, who's a registered nurse and a clinical nurse specialist in epilepsy. Mimi achieved her undergraduate degree at St. Louis University and her master's degree at University of Pennsylvania. She's one of the first, I think, 12 epilepsy nurses in the United States. And she currently works as an epilepsy clinical nurse specialist at Stanford Healthcare at their Comprehensive Epilepsy Center. Dr. Elaine Kyriakopoulos is the Director of Health Communications Engagement at the National Epilepsy Foundation and a clinical research associate in the Department of Neurology in the Comprehensive Epilepsy Program at Dartmouth-Hitchcock Medical Center. She received her Master's of Science degree in the Department of Anatomy at University of Western Ontario, London, Ontario, Canada, and a graduate of McMaster University Medical School in Ontario, Canada. She completed a neurology residency and worked at the Epilepsy Center in Clinical Neurophysiology at Beth Israel Deaconess Medical Center in Boston. So thank you, Mimi and Elaine, for joining us today. Next slide. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. And joining with AANN is one way we can help achieve this, to help those who care for people with epilepsy and in turn helping people with epilepsy. Next slide. So this program is made possible with funding from the Centers for Disease Control and Prevention, and its contents are solely the responsibility of the authors and do not necessarily represent the views of the CDC. And next slide. And Dr. Kyriakopoulos, I'll turn over to you right now.
Thanks so much, Patty, and thanks for the invitation to be here with you today. It's terrific to be here with all of you. Today's webinar focuses on comorbidities when a person's health is impacted by more than one condition at a time. Next slide. The objective for today's webinar really focus on epilepsy and comorbid mental and behavioral health conditions in both children and adults. Next slide. The reason for our mental health focus is explained here. There are approximately 3.5 million people in the United States who live with epilepsy, and between 1/4 and 1/2 of those individuals will also be diagnosed with a psychiatric comorbidity, making this both a complex and very common problem. Next slide, please. We'll begin with an overview of pediatric comorbidities in epilepsy. Next slide. What's been learned over the years about epilepsy is that seizures are just the tip of the iceberg when it comes to impact and challenges that are present in epilepsy. In children, there are several health and quality of life influencers that go beyond the seizures. Next slide, please. So how common are comorbidities? This slide reflects findings from a large study, a patient registry done in Norway looking at over 1 million children. They followed the children over a 17-year period, and they compared comorbidities in kids with epilepsy, both complicated and uncomplicated, with children in the general population. And what they found when they looked at this list of comorbidities was that the children with both complicated and uncomplicated epilepsy had a higher risk for comorbidities than kids without epilepsy. Next slide. In addition, we also know that children with epilepsy have learning problems. This also has a negative impact on their psychosocial and adaptive functioning. It can affect all of the areas listed here, and typically at least 2 or more are impacted to some degree. Next slide. Several studies have helped to elucidate that learning difficulties do not only have an impact on functioning during childhood, but also impact long-term adult outcomes. Additionally, we've learned that this is actually more true for children with epilepsy than kids with other chronic childhood diseases, and really highlights the need to recognize the signs and symptoms of these difficulties early and to intervene as soon as possible. Next slide. If we take a look at a few of the larger studies done in children, a study done in Canada that looked at 337 normal children living with epilepsy, and what they found looking at their outcome at school age was that they were more likely to have failed a grade, more likely to have required consultation from a psychologist or psychiatrist, and they were more likely to have been treated on a medication for a psychiatric disorder. They also found, looking at their outcome in adulthood, that they were more likely to be unemployed, had higher rates of social isolation. Women had quite high rates of inadvertent pregnancy, and about 2% had a criminal conviction. Next slide. Another Canadian study compared young adults with absence epilepsy to another group of young adults diagnosed with a different chronic disease, juvenile rheumatoid arthritis. It found that young adults who had epilepsy in childhood had greater difficulties in their academic and personal lives and more behavioral problems, and that even those who had outgrown their epilepsy still had more difficulties in adult life than the arthritis group. Next slide. And now on to a third study done more recently here in the United States, which looked at children with epilepsy and compared them to their siblings without epilepsy, and essentially, eliminating any home or parenting variables. And what they found was that if a child had uncomplicated epilepsy, meaning epilepsy without any type of intellectual disability, and that child went on to have remission of their uncomplicated epilepsy, that they actually did as well as their siblings. So that was certainly good news. But if a child was not in remission, even if the epilepsy was uncomplicated, children had lower likelihood of graduating high school, greater rates of unemployment or underemployment, and were less likely to live independently. If a child had complicated epilepsy, so epilepsy plus intellectual disability or autism or cerebral palsy, not surprisingly, it didn't matter or not if those kids had remission of their epilepsy. They still did worse than their siblings. Next slide. We've taken a look at the impact of some of the comorbidities in childhood epilepsy and their associated long-term outcomes. The critical point I'd like to make here at this juncture is that some of these comorbidities actually have a more significant impact on overall quality of life than the seizures themselves. And it does, really shed light on the importance of assessing and treating these comorbidities early in childhood. All right, next slide, please. Let's move on now to look at a few of the different potential causes for these comorbidities. Next slide. One of the big factors that we think about is underlying brain disorders. Frequently, and particularly with the early onset severe epilepsies that don't respond well to treatment with anti-seizure medication, epilepsy can be a result of fairly widespread brain abnormalities. And this can be due to a child having developmental brain changes or prior brain injury or an underlying genetic cause. And in some of those cases, even if treatment is able to significantly improve seizure control, it doesn't necessarily take away those comorbidities. Next slide. If we look at various epilepsy syndromes, again, we know that the risk of comorbidities is certainly highest in the early onset epilepsies that are not responsive to anti-seizure drugs. But we also know is that we can see these comorbid diseases in what is often referred to as benign or generally more well-behaved epilepsy syndromes, like benign Rolandic epilepsy, for example. Children with this diagnosis have higher rates of language problems. And in juvenile myoclonic epilepsy, which typically gets diagnosed in the teenage years, patients often have more issues with inattention and memory. And in childhood absence epilepsy, there tend to be difficulties with both language, but also with attention as well. Next slide. Another thing to consider is the number of different core epilepsy characteristics. So we know that epilepsy starts early in life has a higher likelihood to be associated with various comorbidities. And we know that in some cases, very frequent seizure discharges on EEG can be associated with greater learning problems. We know that children who have epilepsy for longer durations have more problems. And it would be fair to say that it's commonly recognized that the medications that we use to treat seizures, while obviously necessary, quite often also have side effects that can certainly exacerbate different behaviors or learning problems. Next slide. One of the most concerning types of epilepsy are epileptic encephalopathies, and these are disorders where there are very frequent seizures. And as you can see here on the snapshot of an EEG on the right, very frequent and almost continuous epileptiform discharges. It's known that in these situations, the very frequent seizures can significantly worsen learning problems. And what is thought to be occurring is that the frequent discharges disrupt the normal brain circuits that support learning. In these cases, it's very, very important to get the best seizure control possible in order for a child to reach their potential. Next slide. Let's review a bit about some of the cognitive or intellectual difficulties when it comes to comorbidities. So first is intellectual disability, which occurs very early during development and includes problems in intellectual and adaptive functioning. Intellectual functioning refers to difficulty with thinking, or what we call cognition, and this does impact a child's ability to learn new information. Adaptive functioning includes things like communication, social skills, and independence. And this can really impede a child's ability to do things at a developmentally appropriate level. So it could be something as simple as learning how to tie their shoes or start to get their routine together for before they go off to school. Now, in order to diagnose, a clinical assessment with psychological testing, including IQ testing, is needed. Next slide. The prevalence of intellectual disabilities is unfortunately skewed towards more severe intellectual disabilities in children with epilepsy. Intellectual disabilities can range from mild to severe, however, and some predictors are listed here. Again, this would include children impacted by some of the most difficult to treat epilepsy syndromes. And this, as one would expect, would have an impact on social outcome. Next slide. Learning disabilities are different. So when we think of a specific learning disorder, this typically presents as being difficulty in one area of academic functioning, and it can differ depending on what subject a child is having difficulty with. It's typically identified by teachers or parents, or when low grades emerge consistently in an academic area, and testing is required for a formal diagnosis. and to ensure both support that support services are implemented. So academic accommodations, cognitive strategies, and tutoring are critical for helping children with learning disabilities. Next slide. In children with epilepsy, we know that there is greater academic difficulty even after we take IQ into an account. And so what this means is that even if a child's IQ is normal, there can still be difficulty in specific learning areas compared to the general population. Next slide. Let's talk a little bit about epilepsy and autism. And we know that autism spectrum disorder is certainly not seen in every child with epilepsy, but the risk is higher. The risk is about 7.4-fold higher in children with epilepsy than in the general population. And risk factors for autism spectrum disorder include intellectual disability, which is probably the biggest risk factor, early onset epilepsy, particularly if that epilepsy starts in the first year of life, drug-resistant epilepsy, and then we know that certain seizure types such as infantile spasms or West syndrome are higher risk. We also know that certain more specific causes like genetic causes of epilepsy also increase the risk of autism in children. Next slide. ADHD is very common in children with epilepsy. It can affect up to 1 in 3, and it's often present at the time of or even before the first seizure. There are some key differences, however, in ADHD and children with epilepsy versus children without epilepsy. And one of the big differences is related to the presence of a number of different subtypes of ADHD. So the inattentive subtype, where a child simply doesn't pay attention but is not very hyperactive, is the one that is actually most common in children with epilepsy. What that means is that these kids are quietly sitting at their desks, not paying attention, as opposed to running around the classroom, disrupting learning for everyone. And so what that also means is that this type of ADHD is less likely to be recognized early on by the teacher, and many of the kids are identified late. The second difference that we see in children with epilepsy is that boys and girls are nearly equally affected compared to if you look at children with ADHD who do not have epilepsy. In the don't have epilepsy group, ADHD is more common in boys. Risk factors include early age at onset of epilepsy, drug-resistant epilepsy, epilepsy that is either generalized and includes things like JME or childhood absence epilepsy, or epilepsy that's localized to the frontal lobe. We also know that certain anti-seizure medications can worsen a child's attention and focus, so that's a concomitant risk. So again, it's really important that we look for ADHD. It's common in kids with epilepsy, and it's often unrecognized and untreated, and as a result, there's a negative impact on learning. One final point is that there's sort of this erroneous fear that stimulants, which are the typical medications used to treat ADHD, can worsen epilepsy. And that's has been shown not to be true. They can be very effective and shouldn't be avoided in children with epilepsy. Next slide. I'll talk briefly here about an IEP and 504 plan because that's really a webinar in and of itself, but IEP stands for Individualized Education Plan, and it describes how the school will provide an eligible student with a free, appropriate public education. A 504 plan provides accommodation for eligible students with a documented physical or mental disability. Both of these are covered under federal law, but under slightly different pieces of legislation. So every child with epilepsy is eligible for an education plan, and the support should be implemented early to ensure the child's learning potential is met. Next slide. We'll shift now to talk a little bit about behavior and emotional problems in children with epilepsy. It's established excuse me, that individuals with epilepsy are more likely to have behavioral problems at an earlier age compared to other children, and that these symptoms can vary. Higher rates of internalizing problems, which simply means that the emotional distress that the children with epilepsy experience, they experience inwardly. So you might see this manifest more with withdrawal complaints or physical symptoms. In epilepsy, there are not necessarily higher rates of externalizing problems or outward symptoms, which would include things like fighting, oppositional behavior, or arguing. First-line treatments for behavioral problems are really behavioral therapies. So one of those would be like a parent-child interaction therapy. And then there are also behavioral strategies that can be implemented by parents at home. Medication is sometimes considered in severe cases, but is not typically recommended in place of behavioral therapies. Next slide. Mood disorders are also quite common. Depression symptoms include sadness, withdrawal, low motivation, irritability. And I want to focus a little bit around the irritability piece, because often this gets missed. So irritability is actually thought to be related to depression, particularly as kids move into the teenage years. And it often gets missed or attributed to sort of normal teenage behavior, but it really is an important warning sign that should be paid attention to. Anxiety, including more persistent worry that interferes with day-to-day activity, as well as more physical symptoms, should also raise flags. If feelings of being overwhelmed are expressed, or a child is complaining more about things like headaches and stomach aches, be sure to factor that into your assessment. Diagnosis is made through screening for this is often done at routine medical appointments, and it can also be made based on self-reporting or collateral reporting from teachers and parents about behavior. And referral to a mental health provider is quite obviously, important. Risk factors in general for developing depression and anxiety include low coping skills, low perceived social support, or low self-advocacy, which is really the sense that a child may feel that they don't have control over what happens. Next slide. We know that depression is higher in persons with epilepsy, and the lifetime prevalence of major depressive disorder is higher. And this can often predate seizure onset, and children we know are at increased risk. So development of depression is less related to epilepsy variables. So things like seizure severity, having multiple types of seizures, is more related to psychosocial factors. The social supports, the coping skills, as well as genetic predisposition, and any family history of depression or other psychiatric disorder would put a child at increased risk. Next slide, please. Anxiety is also quite common. So 16 to 36% of children with epilepsy can have elevated scores on screening for anxiety. And anxiety also minimally correlates with epilepsy variables and is more correlated with comorbid learning disorders, genetic predisposition, and psychosocial factors. Anxiety can be tricky because symptoms can be more of an inward manifestation and not as obvious. And often kids are not necessarily able to talk about anxiety, particularly younger children who might feel nervous but don't really have the vocabulary to express that. Unfortunately, because of sometimes less overt symptoms, anxiety can also go unrecognized, as we mentioned earlier. And we did talk about, and I'll just mention again, that medications, individual and family therapy, and cognitive therapy can all be effective treatments for anxiety. Next slide. I want to touch briefly on suicide risk. We know from the literature in adults that adults with epilepsy are at greater risk of suicide than the general population, but this actually has not been well studied in children. However, based on the frequency and impact of comorbidities, there is reason to believe children may be at increased risk. So some things to be on the lookout for early, before a crisis situation arises, is for if a child has significant behavior changes, If substance abuse comes into play, if a child does things like give his or her personal things away, or expressing that they themselves feel like a burden. Any of those signs should be immediately addressed. Next slide. I want to take just a moment to review that medications are safe and effective, and when indicated, they should be considered as a treatment option for children because tolerability and significant improvement in symptoms has been demonstrated. So 60 to 80% of children will have an improvement in symptoms with stimulants, and studies have shown us that there's not a significant increase in seizure risk with methamphetamines. For mood disorders, SSRIs, so citalopram, escitalopram, and sertraline are generally well tolerated and effective, and that's been studied as well. Next slide. When we think about overall interventions for mood and behavioral problems, a comprehensive approach to treatment tools should always be considered. And a general list includes medications, individual or family therapy, cognitive therapy, and relaxation training. And we know that when the right therapy is instituted and symptoms are well managed, a reduction in seizure frequency has been noted. Next slide. We'll switch gears here to talk about some other comorbidities, which can certainly impact emotional comorbidities, as well as be standalone medical comorbidities. So we'll switch gears and talk about sleep problems, which are important to look for because they can compound other comorbidities. So if a child does not sleep well, they're not going to perform as well at school. There's going to be a tendency to higher rates of anxiety, depression, and greater problems with inattention and focus. Additionally, if you have sleep problems, that's a big factor in preventing you from getting the seizure control that you might otherwise be able to achieve. We know that about 81% of young children with epilepsy actually score in the at-risk range for sleep problems. So this is a really, really important comorbidity to assess with careful consideration of both the physiologic and the psychosocial factors that can impact sleep. Next slide. Moving on to bone health. So we know again that children with epilepsy are at higher rates for bone health problems and fractures. Again, several factors lead to this comorbidity, including the fact that many of our anti-seizure medications can impact levels of vitamin D. Potentially the ketogenic diet impacts some, and restricted sun exposure is another factor. They can all of these things can impact vitamin D, but we also know that preventative treatment, when indicated to lower a child's risk, including supplementation with vitamin D, can help. Next slide. We also know that physical fitness is a really important factor for many reasons. So sports activities provide a good way for kids to socialize, as well as stay physically and emotionally fit. Children with epilepsy may be more limited in sports activities due to fears of injury from unpredictable seizures. However, this has to be balanced because a lack of physical fitness, we know down the road, will predispose them to other comorbidities in adulthood. So try to make it a part of your discussion with patients and encourage families to build in regular physical activity with accommodations if needed. Next slide. Moving on to epilepsy-related injuries, this is a big concern for many families, and a number of studies have actually looked at injury and demonstrated an increased risk in epilepsy. It's important to discuss with families what are reasonable limitations for their child. The goal being to keep children safe but active and engaged. We don't want them to be put at risk for injury, but we also want them to live as normal a life as possible, and there's a real need to balance things out. Next slide. I want to focus just for a minute here. One big concern is drowning injury. And this is the injury that's most likely to result in death or disability. Studies have demonstrated an increased risk for children with epilepsy. Drowning deaths are preventable. And it's so important that families are counseled on the risk and the absolute need for supervision if a child is in a bath or pool or in and around a body of water. Next slide. Detecting comorbidities early is critical. And you'll hear more about this from Mimi in just a short while. All children with epilepsy are at risk, and requests for screening and referral should be initiated early if there is any concern whatsoever. Next slide. Briefly, to review the variables and risk factors, we know that seizure variables predict cognitive comorbidities more than psychiatric comorbidities. Psychosocial and genetic risk factors are important for psychiatric comorbidities. Many of the comorbidities we talked about today are treatable, and early detection and treatment will enhance neurocognitive outcomes and improve quality of life. Next slide. When it comes to comorbidities, as you care for these amazing, resilient kids and their families, remember that children with complicated epilepsy are at highest risk. They typically present early and may precede seizure onset. Multiple factors influence comorbidities. Many comorbidities are treatable, and early and better seizure control may improve outcome and quality of life. And with that, I'll hand things over to my colleague, Mimi Callanan, to discuss comorbidities in adults.
Well, good morning, and I also would like to thank the organizers for inviting me to be with you this morning. So I'm going to talk about adult comorbidities and epilepsy, and as we know, children all grow into adults, and these problems then become adult problems. And I liked the tip of the iceberg slide that Elaine showed earlier, because the seizures truly are just the tip of the iceberg as far as what people with epilepsy deal with. Next slide. So comorbidities, as you've been told, are health conditions that occur more often than chance in people with epilepsy, and they may be a result of the cause of the epilepsy, the consequences of epilepsy, or coexisting conditions. Epilepsy is an unpredictable disorder that is attached to a stigma, and this may make these comorbidities even more difficult for people with epilepsy to deal with. I would like to point out that the psychosocial impact of both epilepsy and the comorbidities present people with epilepsy with a much bigger challenge than others with other chronic illnesses. What I'd like to do is just briefly talk about some of the non-psychiatric comorbidities before we move on and spend most of the time on the mood disorders. So as far as sleep disorders in adults, as we know, some anti-epilepsy drugs can disrupt sleep. We also know that there are increased epileptiform discharges during sleep, and that oftentimes patients only have seizures during sleep. We find that a large number of our patients have obstructive sleep disorder, and so referring these people to sleep clinics and getting them tested for sleep disorders and getting them treated for the sleep disorders will oftentimes make their seizures better. Injuries are very important in adults, especially for the elderly, and these injuries are linked not only to seizure-related falls, but are also related to, especially in the elderly, to side effects of medications. Because especially in the elderly, patients are already on multiple medications. There was a study done years ago that looked at the average number of medications that people in nursing homes took, and that average was like 7 or 8 medications per patient. So then you add on, in addition to that, these epilepsy medications, and that can really make people very unsteady. Burns are also another type of injury that happens to adults with epilepsy. It could be a result of cooking. Patients may have seizures while ironing or curling their hair. I've seen multiple patients with burns. So that's also something that we need to think about when we educate our patients in respect to safety issues. And parents with epilepsy should also be advised not to bathe their children alone in case they have a seizure. I have a patient who lost a child while she was bathing the child because she had a seizure during that time, and there was no one else with her at home at the time. Decreased bone density. This is a very big thing, especially in adults and especially as we age. So we check vitamin D levels on all of our patients, and we supplement them as needed, as Dr. Kyriopoulos has discussed. We also encourage exercise, and we also check bone density scans. We get a baseline, and then we check them, depending on the age of the patient, every 2 to 5 years to look for a change in bone density. And sometimes what we need to do is, if someone is on an enzyme-inducing anti-seizure medicine, or if they're on Depakote, we may need to switch them over to another medication that doesn't have the same effect on bone density. Next slide, please. So what is the impact of side effects on the comorbidities? So the common side effects of anti-seizure medicines are many, but some of the bigger things that we think about are fatigue, which can be mild to severe depending on the individual. They may have cognitive difficulties, they may have changes in mood and behavior, and they may have sleep disruption. They may have a decrease in their bone density. So all of these medications can cause side effects that either can result in a comorbidity or that can mimic a comorbidity or make a comorbidity worse. So the mood or behavior side effects that are related to anti-seizure medications, the behavioral problems most commonly reported are irritability. Patients may have concentration difficulties. They may have hyperactivity, depression, anxiety, and psychosis. As far as possible mood or behavior side effects related to anti-seizure medications, some of the medications can improve mood, and so some of our patients that we have that may be depressed, we may start them on Lamictal. Neurontin can improve mood, although I've also seen Neurontin make mood problems worse. Topamax and Depakote. You can see the medications that are listed that may increase depression. I would add Fycompa to that increased depression, and Briviact as well. As far as increased anxiety, Thalbatol, Keppra, and Briviact can all increase anxiety, and increased irritability and agitation is seen with Zonegran, Keppra, and Fycompa. I would just state that if you put someone on a new medication and the patient complains of any of these side effects, that you should consider that it may be a side effect of the medication, but it may be that it's exacerbating an underlying condition. So I'd like to talk about the prevalence of comorbidities next. Next slide, sorry. So when we talk about prevalence of comorbidities in adults, there are two things that we look at: the mental health comorbidities and the physical comorbidities. And this was taken from a study by Teller and Zenteno, and what they found was the prevalence of any mental health disorder in the past 12 months was 23.5% with epilepsy, with people with epilepsy, and 10%, almost 11% without epilepsy. And that the lifetime prevalence of suicidal ideation was 25% with epilepsy and 13% without epilepsy, which is basically double. And then the physical comorbidities was greater in people with epilepsy for any type of heart disease, stroke, arthritis, migraine. And the interesting thing I found was that people with epilepsy are more likely to have 4 or more medical comorbidities. So that's a lot to deal with in addition to your epilepsy. So depression and epilepsy is the most frequent psychiatric comorbidity. It's estimated that 10 to 20% of people with controlled epilepsy have depression, and that 20 to 60% of people with refractory epilepsy have depression. And those numbers may be conservative. Those numbers may actually be much higher. We also know that there's a bidirectional relationship, and we know that a history of depression is associated with an increased risk for seizures and is associated with a worse prognosis of seizures. And we also know that epilepsy may increase the risk of depression. Next slide, please. So when we look at it in general, according to specific disorders, you can see that in all categories, people with epilepsy have a higher prevalence of all psychiatric disorders than those in the control group. Next slide, please. So this slide lists the more common forms of psychiatric morbidity identified among people with epilepsy. And while there's a consensus that psychopathology occurs more frequently among patients with epilepsy, the actual prevalence of these disorders is really not known. And part of that may be underreporting from patients. The wide ranges listed in this slide reflect the different methodologies and patient populations used for gathering the data reported in the literature. And recent publications have raised concerns regarding under-recognition and under-treatment of psychopathology among patients with epilepsy, which result in part from the atypical clinical presentation of these different types of disorders. I just wanted to point out on this slide that patients are not only at risk for psychosis, for schizophrenia, but patients may also experience what is referred to as post-ictal psychosis that occurs within 24 to 48 hours after a cluster of seizures and responds very well to short-term treatment. Once they're on treatment for a couple of days, their psychosis resolves and they're back to their baseline. Sometimes it's difficult to determine what is the side effect of medications versus depression. And then the other question is this just an adjustment to the diagnosis of having epilepsy, or is it truly an organic problem? Next slide, please. So this is just another way to look at the prevalence of depression and epilepsy. But what I'd like to point out here is that with depression, there are different forms of depression that we see in epilepsy. There is a pre-ictal or pre-seizure depression that may present as prodromes of depression or irritability that can occur a day or several days before a seizure. The patient's not always aware of this, but typically family members are. And then there's ictal depression. Fear is the most common ictal emotion, but depression can occur, and it's usually sudden in onset and not associated with any external factor. and it can occur as a focal unimpaired seizure, or it can precede a focal impaired seizure or tonic-clonic seizure. Post-ictal depression is very well recognized and may last several days to weeks after a seizure, and it may be very significant and result in suicidal ideation. And then, of course, there's the interictal, or just the regular depression. Suicide, the risk of suicide ideation and attempt in people with epilepsy is much higher than in the general population, and may be 4 to 5 times higher than in the general population. In patients with epilepsy, mood and anxiety disorders are frequent psychiatric comorbidities, and they can yield very serious and negative impacts on the management of the seizure disorder and the life of the patient. So they can decrease seizure control, decrease tolerance of anti-seizure medicines, decrease quality of life, and increase suicide risk. Depression and anxiety can be safely treated with SSRIs and are the SNRIs. So when we talk about screening, some of the reasons for underdiagnosing or undertreating these disorders are patient factors such as failure to recognize symptoms, reluctance to seek treatment due to the stigma attached not only to the epilepsy, but also to the psychiatric comorbidities, underestimation of symptoms and severity, limited access to treatment, non-compliance with treatment, inadequate time to actually evaluate and treat patients, lack of social specialists, inadequate dosing of antidepressants, and lack of insurance coverage or limited coverage. So some of the screening tools that we can use that are very brief and can be used in an office visit are the Neurological Disorders Depression Inventory and Epilepsy. It's a 6-item scale. A score of greater than 15 is suggestive of a major depressive disorder. The thing that can differentiate whether this is an adjustment to a chronic illness or depression is the question of difficulty finding pleasure in things that I enjoy. Patients that truly have a depression will answer that they do not find pleasure in the things that they usually enjoy. Then there's also the GAD-7, the generalized anxiety disorder. A score of 10 is, a score of greater than 10 is suggestive of a generalized anxiety disorder. So the aims of pharmacotherapy for patients is remission of all the symptoms of depression and anxiety, to adjust the dose of the antidepressant in the presence of enzyme-inducing anti-epilepsy drugs. So you want to make sure that you get adequate doses and that you adjust the dose of the anti-epilepsy drugs according to the inhibitory effects of the SSRIs. So the most important consideration is that you aggressively treat both the seizures and the depression. So the treatment considerations is to aggressively treat both the seizures as well as the depression. Choose medications that don't exacerbate the epilepsy. It's okay to use medications, they're safe and effective. Cognitive behavioral therapy is also very effective. Family therapy may be needed. And don't forget the caregivers, they also need support. And you can also refer patients to self-management programs that are specific to memory issues, depression, and anxiety. Next slide, please. Another comorbidity that we see is the patient who has non-epileptic seizures or psychogenic non-epileptic seizures. It may be that patients are misdiagnosed with epilepsy and may turn out to have both non-epileptic seizures as well as epileptic seizures, and these should be treated aggressively as well. Next slide. Next slide. So epilepsy, the morbidity and mortality. People with epilepsy are 30% more likely to have accidental injuries. Approximately 10 to 20% of people with epilepsy will have an episode of status, and sudden unexplained death is the second leading neurologic cause of lost potential life years. and epilepsy more than doubles the risk of a patient dying. Next paragraph. Epilepsy, as you can see, is not a benign disease. People can die from epilepsy either during a seizure or due to a complication from a seizure or status. The most common form of death in epilepsy is called SUDEP, which is sudden unexplained death in epilepsy. And they're known to have epilepsy, but there's no obvious cause of their death. The frequency is difficult to determine accurately, but about 2,750 cases of SUDEP occur in the United States every year, compared to, say, 1,575 cases of SIDS, or 2,760 deaths due to accidental exposure to smoke or fire or flames. In 2017, the SUDEP guidelines suggested that 1 in 1,000 adults with epilepsy would die from SUDEP. The risk is higher in people with uncontrolled seizures, thus the importance again of treating patients very aggressively. Next slide. The impact of comorbidities on quality of life is significant. Education, employment, independence, and social isolation are severely impacted. 32% of people with epilepsy can't work, 29% of people can't drive a car, and 21% of people with epilepsy can't pay for medications. Next slide. The indirect costs associated with uncontrolled seizures are 7 times higher than that of the average for all chronic diseases. People with epilepsy, next slide. People with epilepsy have a sense of vulnerability and helplessness, partly as a result of the unpredictable nature of the disease, in part due to fear of having a seizure. Where will they be when it happens? Will people reject them? And this powerlessness may be due to a sense of loss of control or misconceptions about epilepsy. So the most important part of the talk is the next slide. What's the role of the nurse? So we need as nurses to be aware of the issues people with epilepsy face, not just their seizures and medications. We need to be aware of mood and behavior side effects related to anti-epilepsy drugs. We need to be proactive in assessing and screening for psychosocial and emotional impact of epilepsy. We need to be aware of the resources and to refer people as appropriate. We need to be creative with individual patients, and we need to really sometimes think outside of the box to get them help. We need to be aware that epilepsy spans the lifetime and that different issues will arise at different time points. We need to be aware that people already have one chronic illness and are not keen to be diagnosed with another, and we need to be upfront with patients and let them know that this is common and that there's nothing to be ashamed of. And we need to be aware of safety concerns with these comorbid conditions and educate patients appropriately. Just so that you know, there are many self-management programs available. Next slide, please. Next slide. And self-management involves a partnership between a person with epilepsy, the person's healthcare provider, and family and friends. Next slide. And just so that you're aware that there's the MU network programs are available, you can learn more about this by going to their website. Next paragraph, next slide. And these are some of the resources, the CDC Managing Well Epilepsy Network. That's where you can get more information on the self-management courses. I'm going to turn this back over to Patty.
Thank you very much, Mimi and Elaine, for this wonderful presentation.